My name is Hanna Faghfoury, and I'm a clinical metabolic geneticist here in Toronto. I see some faces I recognize. Thank you for inviting me to be here to speak about, I think the title says genetic research, which is pretty broad, but I don't think we can talk about research unless we talk about the new classification of the EDS. I have no financial or other conflicts of interest to disclose at this time. I'll also disclose that I had no part to play in terms of this, setting this new criteria, so I can't take credit nor can I take blame for this. So at the end of this talk, you should be able to describe the rationale for updating the classification of the EDS syndromes, outline the differences between the old and new classifications of EDS, and I'll summarize some areas for future EDS research. It could be an entire two-day symposium onto itself, but we'll chat, particularly because we've talked about education, we can chat about some of the educational initiatives, and that's an area that's near and dear to my heart. So I'd encourage, if you haven't already, to look at, you'd be able to pull this up, the March 2017 issue of the American Journal of Medical Genetics Part C seminars, and the specific issue is entitled The Ehlers-Danlos Syndrome, Reports from the International Consortium of the EDS. And you see a lot of familiar names who were part of the consortium. This, I believe the articles in this journal are open access to any individual. I think Dr. Mendoza touched upon this briefly in terms of the history. There was initial attempts in terms of criteria and nosology established prior to common knowledge of the gene players that were involved in EDS. And then about 10 years later came the Villefranche criteria for EDS. And this occurred when we began understanding the biochemical and genetic aspects. We didn't understand all of them, and there were EDS subtypes that were yet to be discovered, but there was an attempt, and this was the criteria that was used for almost 2 decades, up to the last few years, where there was an increase update that was requested. So at that point in time, there were 9 subtypes of EDS. There are major and minor criteria. And again, there have been a huge, expansive knowledge burst in genetics, which has affected all types of genetic disorders, including connective tissue disorders. So there was a call to update this. Many of you may recognize the Villefranche criteria for the, and I've just put up here the classic and hypermobile subtypes. But as you can see, for the classic subtype, skin hyperextensibility, joint hypermobility, and some unusual and widened scars were major features, and there were other primarily skin features and bruising that were in the minor criteria, as well as a positive family history, as it is autosomal dominant. For the hypermobile subtype, you can see why there was a lot of room for interpretation, and it wasn't really current for all of the extra articular manifestations of hypermobile EDS, as the major criteria was hyperextensibility, generalized joint hypermobility, and then minor were dislocations, pain, and a family history. So the criteria were quite broad, and this has probably led to the huge number of patients who have been diagnosed with what we were calling hypermobility EDS or EDS type 3 in the past. At some point, someone clued in that, hey, maybe joint hypermobility syndrome is one and the same as hypermobility EDS, and this was the Brighton criteria that emphasized more the skeletal features that has been seen in hypermobile EDS, including the marfanoid-like habitus, some of the organ issues, and other issues as well. what I'll tell you is that there has been no specific criteria that had been applied. Even within, say, our genetic center, we'd have lots of debates back and forth in terms of who was applying what criteria. And so certainly within Canada, there was a lot of variability in terms of what criteria were being used to diagnose a patient with EDS. The complicating factor when you don't have a molecular diagnosis is we have no way of knowing whether this diagnosis is actually quote unquote correct or not. So here comes the 2017 international classification, the ones that were published in 2017, where we have 13 subtypes. There were some subtypes that were included and some that were removed. What is important to note is to be part of the EDS subtype, they all have in common joint hypermobility, skin hyperextensibility, and tissue fragility. And this is why there is a relative emphasis of these features in terms of the major and minor criteria as well. The aims were to regroup the EDS subtypes based on genes and pathway function, obviously with the exception of hypermobile EDS, for which we've unfortunately not delineated a genetic cause. And the aims were actually to provide a standardized framework for the management, and we wanted, as much as possible, the idea was to have as homogeneous enough cohorts for future genetic research. Now, this means that the criteria, by definition, become stricter, but we'll go into a little bit about that. So these, again, pretty small font, I apologize. These are the 13 subtypes that you see here, with classical EDS number 1, classical-like EDS, cardiac valvular, which wasn't part of the previous classification, I believe, and vascular EDS, and then you have hypermobility EDS as well. This table outlines the genetic basis and the protein encoded by the genes. So I'll go into some detail about the criteria for hypermobile EDS, as that is, as was mentioned, of great interest to a large number of patients. The term hypermobile EDS replaces the term EDS type 3, hypermobility type EDS, and hypermobility syndrome. It still remains a clinical diagnosis. We still believe that this is a heterogeneous condition, meaning there are multiple genes that are at play, with very important contributions of age, sex, and other environmental factors, although we know there's a strong genetic component based on familial studies and twin studies and things like that. And the aim of the new criteria, as I said, is to reduce the heterogeneity so we can facilitate the discovery and treatments for this syndrome. So I'll speak briefly about attempts to discover the genetic basis. The bias in the literature is for positive studies. So a lot of the negative large studies that have not bared any fruit has not been published. But I know anecdotally there have been large groups and large cohorts where there have been various quality genetic research, and I know even locally we have completed some exome and even genome, I believe, on specific families that look very compelling for one single genetic cause, and we have not yet determined this. So whether it's a genetic mechanism that is not a standard genetic mechanism or a part of the genome that is really difficult in terms of detection, or probably more likely that we, again, don't have good homogeneous cohorts of patients, still is yet up for debate. There's one case report, it's an old case report right now, so I would worry about the kind of quality of the data, but it's where there was a report of a collagen 3A1 variant in a patient with hypermobility EDS. And a variant of, this is more recent publication where in 4 Belgian families there has been a gene variant that has been seen, but it hasn't been found to be a major player in the larger cohorts tested. So going to the new criteria, a clinical diagnosis of hypermobile EDS needs simultaneous presence of criterion 1, 2, and 3. So you need to meet all of these criterions. Criterion 1 is one we know well, generalized joint hypermobility. Now, depending on whether you are applying the Brighton score or the Villefranche criteria, you needed a Baton score of 4 over 4 or 5. And again, there was no discussion in terms of prepubertal or the loss of hypermobility with age. And this current criteria, they try to address that, because we were probably overdiagnosing children who were naturally flexible, underdiagnosing adults who lose their flexibility over time or who sustain injury and who aren't able to complete the Baton score. So the Baton score, to be a positive for generalized joint hypermobility, you need over or equal to 6 in prepubertal children or adolescents, and I've put the Baton score there, although any patients in the audience have probably had this completed at least once during their lives. Pubertal adults up to 50 years of age, it would be over or equal to 5, and over 50 years of age would be over and equal to 4. So the 85-year-old patient I saw with a Baton of 9, that is probably, that is likely pathological to some degree. And so we see mobility decreasing over time naturally. Now, what if the patient has acquired joint limitations or because of pain cannot actually perform the Baton score? Generalized joint hypermobility is diagnosed if the patient has 1 point below the Baton score cutoff and answers yes to 2 out of the 5 questions on this 5-point questionnaire. It's otherwise known as the 5PQ in the literature. And so the 5PQ, the first question is, can you now or could you ever place your hands flat on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearms? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do splits? We call, in our clinic, sometimes I say, were you able to do kind of party, like tricks as a kid? And do you consider yourself, did you dislocate your shoulder or kneecap on more than one occasion? And do you consider yourself double jointed? If you answer 2 out of 5 questions, that could be a surrogate if you meet 1 point below the Baton score cutoff. This has a sensitivity of 80 to 85% to diagnose joint hypermobility and a specificity of 80 to 90%. Now, I know there's ongoing debate in terms of the value of the Baton score because it's only looking at limited joints, but unfortunately there isn't enough literature validating looking at the other joints, and there isn't enough objective, measurable ways that we can measure hypermobility at this point in time for the other joints. So we still are very interested in hypermobility in those other joints, and we'll generally ask about them, but it's not part of the criterion at this time. Okay, so this is where things get a bit more complicated. So criterion 2, you need to fulfill 2 or more of the following features in group A, B, or C, or like combination of there. So A and B, A and C, or you can fulfill all 3. So the first is patients need to have systemic manifestations of a more generalized connective tissue disorder. So they need to have 5 out of 12 of the following features. So unusually soft or velvety skin, mild skin hyperextensibility, unexplained striae, bilateral pyogenic heel papules. These are papules that are on the bottom of the heels, recurrent or multiple hernia, so like, and again, recurrent, atrophic scarring, organ prolapse, dental crowding, and high narrow palate, long fingers and toes, arachnodactyly, arm span to height greater than or equal to 1.05, mild mitral valve prolapse, and aortic root dilatation. So that's 13. Those are 13. You need to have 5. And I'm told that this is where a lot of patients who are historically diagnosed as hypermobile or type 3 EDS may be lacking features to fulfill the new criteria. A positive, B is a positive family history of 1+ first-degree relatives. Those are either siblings, children, or parents. independently meeting the current diagnostic criteria for EDS. So you see kind of the complicating factor here if your first-degree family members have never really been formally assessed or haven't been reassessed. And the last is musculoskeletal complications, which most of our patients historically diagnosed would meet easily, which is pain in 2 or more limbs recurring daily for at least 3 months, chronic widespread pain for over 3 months, and recurrent joint dislocations in the absence of trauma. So they need a minimum of 1 out of 3, which I guess most patients would easily meet. All of the following prerequisites must be met to fulfill Criterion 3, which is the absence of unusual skin fragility. Now again, a lot of these, unless you have experience in EDS, it's really, it's sometimes difficult to appreciate the nuances between unusual skin fragility and just regular skin fragility. In the document, and there have been other specific dedicated articles on skin manifestations of EDS, they give examples of typical scarring and features in hypermobility EDS and hypermobile EDS versus classical EDS. And I'll tell you that there was a time where I was sending genetic testing on all comers, and the only patients where I found mutations in were patients with classical EDS, and they had very, very striking skin features that I probably wouldn't have missed. And there were really no patients that with hypermobile EDS that I saw that had even skin features that I thought may be out of the ordinary where we detected mutations in those patients. We need to be able to exclude other hereditable and acquired connective tissue disorders, including autoimmune disorders such as rheumatoid arthritis and lupus. And we need to be able to exclude alternative diagnoses that cause joint hypermobility, like osteogenesis imperfecta. And that's why, at least in the adult clinic, we've worked really hard in terms of creating a standardized assessment form so that we're not missing patients that may be actually diagnosed under other categories of connective tissue disorders. Okay, so I know the elephant in the room is, well, what about all these other features that are going to be taking up the bulk of a lot of the discussion in the next 2 days? Such as sleep disturbances, fatigue, some of the dysautonomia and postural orthostatic tachycardia syndrome, functional GI disorders, and the anxiety and depression, where these features are actually contributing to a lot of the morbidity and disability in our patients. The problem is, at this current time, we don't have enough information to say that these findings are specific and sensitive enough to be included in criteria, particularly when, again, the joint skin features are weighted so heavily in terms of the classification of the EDSs. We'll talk a little bit more about that moving on. So again, the way now currently to think about it is that, and we used to think about it somewhat this way, is that if you have joint hypermobility, you can be asymptomatic where you have really no problems related to this. In fact, you may use a lot of that hypermobility to your advantage in terms of sports and things like that. And you may never have any issues in your lifetime that cause you any disability. In the other category are patients who have symptomatic joint hypermobility. And within those, you have now a much narrower subgroup of patients who have hypermobile EDS. And then a lot of patients who were formally diagnosed as hypermobility EDS or EDS3 are being put in a category called hypermobility spectrum disorders. And so when I was reading a little bit more about this in the last few months and even leading up to this talk, at first my inclination was to say, well, this is kind of like a grab bag of everything that isn't this small, narrow field. But I think we have an opportunity to even define the phenotype within this hypermobility spectrum disorder to see, is it one and the same eventually as hypermobile EDS, or are there other factors that are at play there that are very distinct from hypermobile EDS? The only way to really determine that is by discovering pathways and genes that are important for each of these subcategories, and doing a really, really diligent and careful job in terms of phenotyping. So that means really from head to toe, and that's where head to toe determining what are the morbidities and features of these patients at a given snippet in time and also over time. And so this is where registries become quite important. And again, keep in mind that in terms of symptomatic joint hypermobility, there are other conditions and genetic syndromes, including other forms of EDS. We talked about osteogenesis imperfecta. A lot of other genetic syndrome has symptomatic joint hypermobility as a feature, and we know the genes for these. So are there lessons to be learned from these other rare disorders that may actually apply to hypermobility spectrum disorders and hypermobile EDS? So the new terminology within the spectrum updates the terms that were used to define patients. But we all know that clinical diagnostic criteria without a known molecular cause will by definition be imperfect at best and arbitrary at worst. So we really need to be, again, diligent about these subcategories and kind of stick with it for a while at least to see if there's any yield in terms of gene discoveries. The definition, I think everybody is realistic that the definition of hypermobile EDS will likely change over time once we actually understand the underlying pathophysiology of the symptomatic joint hypermobility. So there is this term that's thrown around in some of the articles in this issue saying that this is potentially a more of a kind of a dynamic definition. But again, it's hard to know. Okay. And so future directions, so stringent application of criteria will allow for more standardized classification. It's really important. We're trying to spearhead patient registries so that we can delineate all the risk factors and comorbidities to set groundworks for evidence-based treatments. Molecular studies can be more efficiently completed on homogeneous populations, and we may discover other subtypes of EDS which may help us understand the more common subtypes. We've said this, there's a lot of medical professionals that keep saying we need randomized controlled trials. Patients say we need treatment now. And so these often seem to be at odds. But really it is still the gold standard for medical intervention. So this applies to areas of pain management, psychiatric care, gastrointestinal areas, as well as orthopedic. Mast cell dysfunction, so a lot of the immunological features are not entirely well understood in this population, as well as fatigue. Now, and I won't go into details because again, this will all be covered in terms of need for further investigations throughout these talks. But again, and the neurosurgical piece seems to be quite important as well, particularly when resources are potentially limited in certain areas. So again, a lot of my patients will be concerned about the obstetrics and gynecologic issues. I think this is an important avenue to investigate. I don't want to forget about other rare cohorts of vascular EDS. A lot of patients do ask about best practice for medical surveillance and surgical intervention, and sometimes I wonder whether medical surveillance is more therapeutic for the healthcare practitioners rather than the patients themselves. And improvement, and again, I'll end with the educational piece. I'm actually one of the undergraduate leads for genetics at University of Toronto, so I can speak to the fact that I've worked really hard in terms of having students identify rare conditions in general, and in terms of incorporating EDS into the curriculum. And but I think education needs to happen at all levels. So this happens at in terms of educating our generalist peers, our subspecialist peers, as well as the general population as well. So again, I think, but it needs to come with probably research to see if those educational interventions bear any fruit. Okay, so to summarize, I think the summary kind of speaks for itself in terms of what I said. I'll take a few questions